Welcome to the Vet and Crit Academy, where we discuss veterinary emergency and critical care and science-based tools for vet professionals. Hey everyone! In this video, we're going to dive into 3 fascinating veterinary papers that might just change how you practice, or at least give you some useful insights from the latest research. Here's what you'll learn by the end of this video. First, we'll explore how early ultrasound screenings can help detect intestinal dehiscence after surgery in dogs and cats, potentially saving lives by catching complications before they turn critical. Next, we'll break down how pericardiocentesis impact hemodynamics and caudal vena cava to aorta ratio in dogs with cardiac tamponade. Finally, we'll look at a study on preventing hypothermia in small dogs during surgery by using an easy and affordable method, wrapping their limbs with polyester covers. All right, let's dive into the first paper. This study focused on evaluating the use of early post-operative ultrasound to detect intestinal dehiscence after small intestinal surgeries in dogs and cats. Intestinal dehiscence is one of the most severe complications following these surgeries, occurring in 7 to 15% of cases. When it happens, it often leads to leakage, septic peritonitis, and even death. The study analyzed the medical records of 114 cases, 31 cats and 83 dogs who underwent either enterotomy or resection and anastomosis. These patients had a post-op ultrasound performed between 48 and 96 hours after surgery, which was interpreted by board-certified radiologists or radiology residents under supervision. The researchers were looking for signs of dehiscence using ultrasound to evaluate parameters like wall thickness, presence of steatitis, intestinal peristalsis, local effusion, gas bubbles, and any intestinal wall discontinuity. Here's what they found. Of the 114 cases, 7 dogs were suspected of intestinal dehiscence based on ultrasound findings. None of the cats in this study developed dehiscence. Of the 7 suspected cases in dogs, 6 underwent revision surgery, and in every one of those cases, leakage at the surgical site was confirmed. The remaining dog's owner declined revision surgery, but remarkably, that dog survived and was in good condition 6 days later. For the 107 cases without ultrasound detected dehiscence, the survival rate was 100%. Among the confirmed dehiscence cases, the survival rate after revision surgery was 83%. Altogether, this gives an overall survival rate of 99.1%. The main factor that was associated with dehiscence in this study was the presence of preoperative hypoalbuminemia. In fact, 50% of the dogs with dehiscence in the current study had hypoalbuminemia compared to only 4.6% of those without it. Low plasma albumin as a risk factor for intestinal dehiscence was previously reported in the veterinary literature. By the way, you can watch a completely free workshop on acid-base analysis in dogs and cats by clicking the link below located in the description. Now, let's switch gears and talk about how post-op ultrasound helped identify the cases with and without intestinal dehiscence. In patients without dehiscence, the typical ultrasonographic findings included focal wall thickening with reduced or absent layering, regularly spaced hyperechoic foci like sutures or staples with no gas in the wall, hyperechoic fat consistent with steatitis or edema, and minimal or no intestinal loop corrugation or ileus. In contrast, patients with dehiscence often showed the following findings: So-called intestinal wall discontinuity, in other words, gaps or spacing between the two sides of the surgical site filled with digestive content or gas, as well as severe surrounding steatitis, focal fluid with or without gas bubbles, and finally, ileus and intestinal corrugation, which were more pronounced in these cases. Imaging features that overlapped in patients with and without dehiscence included focal wall thickening and reduced or loss of wall layering, as well as ileus and intestinal loop corrugation. The presence of visible intestinal wall discontinuity had a sensitivity and specificity of 100% to detect intestinal dehiscence, making it a highly reliable finding. The presence of local effusion at the surgical site was 100% sensitive and 82.4% specific to detect dehiscence. The third most accurate finding was the presence of gas bubbles within the wall that had sensitivity of 66.7% and specificity of 93.5% to detect intestinal dehiscence. Of course, the study had some limitations. It was retrospective in nature and was conducted at a single center, which could affect the broader applicability of the findings. Additionally, many ultrasound images were lost due to the technical issues, and the ultrasound reports weren't analyzed blindly, which could introduce some bias. So, what are the main takeaways? First of all, this study suggested that early ultrasound screening performed systematically by board-certified radiologists or radiology residents within 48 to 96 hours after intestinal surgery may potentially identify dehiscence early, before clinical signs of septic peritonitis develop. The identification of the surgical sutures or staples during ultrasound examination was possible in a majority of the patients. The mean time between the first intervention and the revision surgery was 3 days, with a range of 2 to 4 days, which is similar to previously published research. While it may not be practical to perform an abdominal ultrasound on every single patient after intestinal surgery, selectively screening high-risk patients, like those with septic peritonitis before surgery or low plasma albumin levels, could in theory help catch intestinal dehiscence early and improve outcomes. In the comments below, let me know if, after reading this paper, you would consider performing an abdominal ultrasound in this population of patients. I believe there is not one definitive right answer here. Next, we will talk about a recent study that looked at the impact of pericardial centesis on hemodynamic parameters and the caudal vena cava to aorta ratio. Pericardial effusion affects up to 0.43% of all dogs seen at referral hospitals, according to one study. And that number jumps to 7% in dogs with suspected heart problems. The terms pericardial effusion and cardiac tamponade are not the same. The main difference between the two is that cardiac tamponade occurs when fluid in the pericardium compresses the cardiac chambers, impairing the ability to fill up and pump blood. This situation eventually leads to obstructive shock, a life-threatening condition that requires immediate pericardiocentesis to resolve the external pressure on the cardiac chambers. By the way, you can download a free PDF copy of the Diagnosis of Shock checklist by clicking the link below located in the description. On ultrasound, tamponade can be diagnosed by diastolic collapse of the right atrium, but ultimately, this is a clinical diagnosis that involves the physical examination findings and response to the pericardial tap. Recently, the caudal vena cava or CVC to aorta ratio has emerged as a diagnostic tool to help emergency veterinarians distinguish cardiac tamponade from simple pericardial effusion. A normal ratio may range from 0.93 to 1.32, but dogs with cardiac tamponade often show a significantly increased ratio due to a distended caudal vena cava. In the current study, the CVC diameter and CVC to aorta ratio were measured following a previously described protocol. Here's how it worked. First, the left kidney was located using the splenorenal view. Then the ultrasound probe was moved slightly farther back, angled upward, and rotated 90 degrees to get a clear transverse view of the caudal vena cava and aorta. The best cross sections of both vessels were visually identified and their diameters were measured using beam mode ultrasound. For accuracy, the measurements were taken as perpendicular lines across the walls of each vessel. This data included 2 perpendicular diameter measurements for each vessel. In the current study, the authors included 22 dogs diagnosed with cardiac tamponade at 2 veterinary hospitals in France. Diagnosis was based on point-of-care ultrasound results, including the presence of pericardial effusion and right atrial diastolic collapse. Before treatment, the dogs underwent IV catheter placement, physical exams, systolic blood pressure measurements, lactate level assessments, and point-of-care evaluations of the CVC to aorta ratio, along with checks for pleural and abdominal effusions and B-lines on lung ultrasound. Pericardiocentesis was performed under ultrasound guidance, and sedation with butorphanol or fentanyl was given as needed. Overall, the study dogs were predominantly older, medium to large breeds with a median age of 12 years and a median weight of 31 kilograms. A significant proportion showed clinical signs of obstructive shock, including weak pulses, cold extremities, pale mucous membranes, and altered mentation. The median lactate level before pericardiocentesis was 6.15 millimoles per liter, with only 2 dogs showing normal levels. At admission, the median CVC to aorta ratio was 1.76, ranging from 1.35 to 2.13, which was far above the normal range. All dogs showed an increased CVC to aorta ratio, confirming its role as a diagnostic marker. So, what happened after pericardiocentesis? As expected, the median heart rate dropped significantly from 167 beats per minute to 100 beats per minute, which is a 40% reduction. The median systolic arterial pressure improved from 84 millimeters of mercury to 104.5 millimeters of mercury. The median lactate levels decreased significantly from 6.1 to 3.6 millimoles per liter. These changes indicated rapid hemodynamic stabilization within just 30 minutes of the procedure. The ultrasound criteria for cardiac tamponade were also resolved in all dogs. Most importantly, the median CVC to aorta ratio dropped from 1.76 to 1.12, returning to the normal range in 18 out of 22 dogs. Interestingly, while the CVC to aorta ratio normalized in most dogs, 3 still had ratios slightly above the upper limit at 1.51, 1.39, and 1.33. This highlights the variability in recovery and the need for continued monitoring. So, what can we learn from this study? First of all, as we all expected, pericardiocentesis led to rapid improvements in heart rate, blood pressure, respiratory rate, and lactate levels, demonstrating its effectiveness in stabilizing dogs with cardiac tamponade. Second, CVC to aorta ratio above 1.3 was shown to be a valuable diagnostic marker of cardiac tamponade physiology, and its normalization post-procedure suggested treatment success. Like any study, this one had its limitations. Since the ultrasonographer was aware of the treatment, it could have influenced the measurements of the CVC and aorta, potentially introducing bias. It's also worth noting that the measurements were taken using two different ultrasound machines, which varied in type and quality, along with differences in probes used. Our next paper is about hypothermia in small dogs during surgery, a common but preventable issue. The study looked at whether wrapping dogs' limbs with covers could help keep them warm and reduce the risk of hypothermia during anesthesia. If you work with small dogs or are curious about practical ways to improve surgical outcomes, stick around. Hypothermia is a big deal during anesthesia, with over 80% of dogs experiencing body temperatures below 37 degrees Celsius or 98.6 Fahrenheit if no thermal support is provided. For smaller dogs, especially those under 6 kilograms, the risk is even higher. Why is this important? Well, hypothermia can cause all sorts of problems, including delayed clot formation, bradycardia, hypokalemia, prolonged extubation times, and even altered drug metabolism, which could complicate recovery. By the way, you can enroll into completely free, RACE-approved online training on intravenous potassium supplementation by clicking the link below located in the description. So, how do we prevent hypothermia? Common methods include warm air blankets, heated saline for abdominal surgeries, and thermal wraps. But these can sometimes interfere with the surgical field. This current study tested an easy and affordable option, wrapping the dog's limbs in polyester covers to retain heat during surgery. This study was conducted at a teaching hospital in Japan and included 66 client-owned dogs, all weighing less than 15 kilograms, who were undergoing soft tissue surgery. The dogs were split into two groups. Control group received standard thermal support, including a warm air blanket set to 42 degrees Celsius or 107.6 degrees Fahrenheit. And the limb wrapping group got the same thermal support, but with their limbs wrapped in polyester table leg covers up to the mid-metacarpal and metatarsal regions. The researchers measured rectal temperature at several points. At intubation, at the surgical incision, 15 and 30 minutes after the incision, and at the end of surgery. Now let's break down the findings using figure 3 from the paper, which illustrate the changes in rectal temperature over time for both groups. In the graph, the control group is shown with gray box and whisker plots, while the limb wrapping group is represented by white box and whisker plots. At intubation, both groups started at about 38.1 Celsius or 100.6 Fahrenheit with no significant differences. By the time of the surgical incision, temperatures dropped slightly in both groups, but the limb wrapping group maintained slightly higher temperatures, 37.1 versus 36.8 Celsius or 98.8 versus 98.2 Fahrenheit. Though this difference wasn't statistically significant yet. 15 minutes after incision, the limb wrapping group had a significantly higher temperature at 36.9 versus 36.5 Celsius. 30 minutes after incision, the gap widened even further, with the limb wrapping group at 36.8 Celsius or 98.2 Fahrenheit compared to 36.2 Celsius or 97.2 Fahrenheit in the control group, a statistically significant difference. By the end of surgery, temperatures were at their lowest in both groups, but the limb wrapping group still had higher rectal temperatures at 36.7 Celsius versus 35.9 Celsius or 98 Fahrenheit versus 96.6 Fahrenheit. Overall, incidence of hypothermia was much lower in the limb wrapping group, 19 out of 30 dogs compared to 28 out of 30 dogs in the control group. What does this mean for your practice? It is very hard to argue with the fact that limb wrapping is simple and cost-effective. Based on the current study, polyester covers and likely even regular socks can make both statistical and clinical difference in managing body temperature during anesthesia. This method may be especially useful for smaller dogs who are more prone to hypothermia. While this study showed clear benefits, the authors note some limitations. For example, the anesthesia protocol, underlying diseases, and other factors were not fully standardized. In addition, the number of limbs wrapped varied depending on the operative procedure. And finally, this study was limited to a single institution, which may introduce biases related to the surgical procedures and anesthetics used. That said, I believe it's a promising step toward better hypothermia prevention in veterinary medicine. All right, I hope you enjoyed this video. Before you go, leave a comment below sharing your thoughts on these 3 papers and whether any of them might influence your clinical practice. Thanks for watching, and I'll see you next time. Bye-bye.